Well, good morning and welcome to the committee meetings for the Health Policy Commission. I'm David Seltz, Executive Director of the Health Policy Commission. We have two jam-packed committee agendas this morning for you. And so we're going to dive right in with our meeting of the Market Oversight and Transparency Committee. And I'm going to turn it over to the chair of this committee, Professor Cutler, Commissioner Cutler. Good morning.
Good morning, David. It's great to see you, and it's great to see all my fellow commissioners. I hope everyone is doing well, and I hope people watching are everyone is staying safe and all. We do have a full agenda, and as people know, we've been very busy as a commission. And so some of the issues that we've dealt with as a commission are going to come into this committee. So I'm going to get us started, and I'll try to keep us on time, although these issues are of sufficient import that I do want to give us a chance to talk through them. The very first item is that we have the minutes from our previous meeting, which was in October. And so the first question is, does anyone have any amendments to make to those minutes? If not, I believe what I need someone to offer a motion to approve the minutes.
So moved.
And then I need a second.
Second.
Okay, and because we're on Zoom as opposed to in person, Colleen, I believe you need to call the roll. Is that correct?
I will help out with calling the roll today, Commissioner Cutler. So we'll start with you, Commissioner Cutler.
Approve.
Commissioner Haupt.
Approve.
Commissioner Master Giovanni.
Approved.
Thank you. And Commissioner Roeder.
Approved.
And Commissioner Foley is not with us this morning, Commissioner Cutler. So we are approved on the minutes.
Okay, excellent. So we have 4 substantive topics that we want to cover in the next hour and a half. So just to give people a sense of what they are, we want to hear the annual report of the Office of Patient Protection, which is obviously something we don't talk a lot about, but is obviously extremely important for people. And so Nancy Ryan will talk about that. Then we have data points on maternity care, and Sasha Albert will tell us about that. Children with medical complexity, which is just a kind of a very vexing issue. And again, Sasha Albert will tell us about that. And then finally, Cara Vidal will lead us through the process for the performance improvement plans, which obviously we discussed at our we voted upon at our last full commission meeting, but we want to talk about it in terms of the process and in this committee, so we can be prepared for it. So we will try and get through all of those by 11. As I say, I don't want to cut things off, but just please keep. I'll ask my fellow commissioners and myself, of course, to keep in mind that that's what our agenda is for today. David, without further ado, David Seltz, I'm going to turn it over to you to introduce the Office of Patient Protection.
Great. Thank you, Commissioner. And as you said, 2 full agendas. If you are going to be with us for the committee meeting after this, and we hope that you are, it is really a 3-hour tasting menu of everything that the HPC does. We're really going to cover every single lever that the HPC uses to advance its mission. Our role as a researcher, as a convener, as a partner, and as a watchdog. So we're going to start with the role as a watchdog and our role in helping to ensure that the residents of the Commonwealth have their rights when it comes to health insurance and the benefits thereunder. And so the office that helps ensure these rights and works with our constituents to make sure that they get the benefits they rightly deserve is our Office of Patient Protection, which works directly with the residents of the Commonwealth. And so we tend to have a kind of an annual update of our Office of Patient Protection, and we'll go through some of the numbers from our annual report to give you a sense of the activities of this office. I'm going to turn over to Nancy Ryan to do that, but as always, feel free to ask questions along the way about the office and the role that it plays. So with that, I'll turn it over to Nancy, the Director of Office of Patient Protection.
Thank you.
Good morning, Commissioners. I'm here to present findings from the 2020 Office of Patient Protection's annual report, as David said, and it details our work assisting consumers with healthcare access issues. And this first slide just goes into an overview, reminding everybody of OPP's 4 primary services offered to consumers. First, we allow for the opportunity for people to purchase health insurance outside of the open enrollment period for those who have missed the open enrollment period by offering them a waiver. We regulate and administer health insurance appeals for consumers who have been denied coverage of a treatment or service by their health insurance company. We also regulate and administer appeals for patients of accountable care organizations and risk-bearing provider organizations who've been denied a referral or other service by their provider. And finally, we operate a hotline and answer online inquiries addressing a wide number of patient concerns. So we're going to talk about those 4 services today and our work in 2020. If you want to go to the next slide. This is just a little bit of a year in review. It goes without saying that 2020 was a unique year for the Office of Patient Protection and presented different challenges and opportunities than in previous years. On the operations side, OPP transitioned to a fully remote office in March. We were able to meet the consumer need in a way that we have never done before, with no interruption to our hotline or external reviews. We also transitioned to using all electronic record keeping and really created an opportunity given the circumstances of the year. But the substance of our work was also impacted by the pandemic. We collaborated with the Division of Insurance regularly to ensure continued consumer access to healthcare amidst the many changes that happened to our healthcare system that year, specifically related to the changes in insurance coverage. We saw fewer hotline calls and many fewer open enrollment waiver requests in 2020, but a similar amount of health insurance external review requests. And although we had only a few reviews that dealt with care directly related to COVID, the medical reviewers contracted by OPP throughout 2020 took the circumstances of the pandemic into account when deciding external reviews. For example, access to timely care given pandemic restrictions, and also the expansion of telemedicine played a role in some reviews received in 2020. So if we go to the next slide, we can dive into the data from the office's work in 2020. This first slide details OPP's first consumer service, issuing waivers for those consumers who missed the open enrollment period. As you can see, OPP saw a major decrease in waivers requested in 2020. This is directly due to the fact that consumers could access insurance without a waiver for most of the year. Open enrollment was extended in 2020 as part of the protections afforded to consumers because of the pandemic. So people just frankly didn't need a waiver to access insurance for most of the year, and that would account for the downturn in waiver requests. As usual, for the waiver requests we did receive, we approved the vast majority of them. And in addition to processing waivers, OPP works closely with the connector in 2020 and every year to assist consumers enrolling in health insurance and to troubleshoot complicated situations that consumers may face in accessing enrollment in health insurance. If you want to go to the next slide. Now we're going to go into the health insurance appeals process. This slide details the health insurance internal appeals. Health insurance companies reported receiving over 11,000 internal appeals from members in 2020. This number is slightly less than in previous years and represents all appeals received, not just those related to medical necessity. Just under half of these would be those related to medical necessity. And as you can see, 50% of all appeals received by the health insurance companies resulted in coverage for the patient. And this is similar to previous years also. The next slide goes into the process that OPP administers. For those consumers who were denied at the internal appeal administered by their health plan, 240 of them requested an external review from OPP. The external review that we administer through contracted healthcare professionals is the second level of appeal that consumers go through to have their case examined by those independent healthcare professionals and doctors with whom we contract. In 2020, consumers were granted the requested coverage in just under half of the eligible cases processed by OPP. These numbers are also similar to previous years. Around 50% of people coming to OPP have their requested outcome by the end of the process. The next slide details the outcomes of medical, surgical, and behavioral health external reviews. The annual report goes into much more detail into the specific types of reviews that OPP processes and their outcomes, but just wanted to give you a quick snapshot of the medical, surgical, and behavioral health external reviews here, broken into those two categories. OPP received fewer behavioral health external reviews than in previous years. This is a continuing trend. Every year for the past few years, we've received fewer and fewer behavioral health external reviews. And 71% of the behavioral health reviews were decided in favor of the member. As you can see, this is a higher percentage of reviews decided in favor of the consumer compared to the medical surgical reviews, but this is a really, really small number, particularly in 2020. OPP only processed 17 external reviews related to coverage for behavioral health care in 2020. So it's a really small number, but did just want to, have that breakdown, but there are more breakdowns by type of service in the actual report. The next slide goes into the newer appeals process, the newer consumer protection that is regulated and administered by the Office of Patient Protection. This slide shows the outcome of internal appeals processed by risk-bearing provider organizations and accountable care organizations. This is the process where patients can challenge decisions by their provider organization related to referrals, type or intensity of service, timeliness of service, and other concerns. The first level appeal, just like in the health insurance context, is at the provider organization. And as you can see, the majority of internal appeals were upheld by the RBPO or ACO. This is actually, fewer were upheld in 2020 than in previous years. That is something sort of notable that we looked at in 2020. In terms of type of appeals, over 90% of these appeals related to referral restrictions. This is entirely consistent with what we've seen since the beginning of this process. In terms of the external review process, in 2020, OPP only received 2 requests for external reviews. This is a major it's always small numbers in this process because it's relatively new, but this is, of course, a very small number. I think, it had to do possibly with some of the, the pandemic and people not accessing healthcare services as much, particularly in March through June. So that both of the requests that OPP received for external reviews were related to referral restrictions, and both of them actually were upheld by the external review agency. The next slide gives a little bit more information about our consumer assistance and information. We assisted 887 consumers via our hotline in 2020. This is about 400 fewer hotline calls than we've received in the previous year. I think that there were many fewer calls to the hotline in 2020, at least partly related to the extended open enrollment period, because our hotline does field a lot of calls related to requesting a waiver. And we did not see an influx of calls related to COVID. I think this is generally a good thing, showing that the state did a good job of informing the public and directing them to the correct resources. Of course, calls related to COVID and calls related to other areas where we're not the primary resource, we make every effort to provide a referral and provide information and resources to that consumer, and we do that through our collaboration with state agencies and also our relationships with community organizations. I've also included a quote from a consumer who requested assistance from OPP. This is one of the many people who we assist every day, and just wanted to give you sort of a flavor of our interactions. And the next slide gives you a brief update moving into 2021. We saw a continuation of trends that began in 2020, continue to 2021. Open enrollment was extended again, resulting in fewer waivers to OPP. We launched online consumer forms, so consumers can apply for a waiver, external review, submit an inquiry, all through our website. That I think is a major benefit for people, especially, given the pandemic. And we've really tried to make that a seamless process for people. And we continue our collaboration and our outreach. And have seen an uptick in hotline calls in 2021, and also an uptick in RBPO external reviews in 2021, both of which I think makes sense. So we've been definitely kept busy as usual, and looking forward to continuing our work in 2022, and happy to answer any questions that the commissioners may have.
Thank you. Patty, why don't you go ahead and start off?
Just a quick question. I'm not sure if you track this or not, but as far as your appeals that you're adjudicating from fully insured plans, is there a particular carrier that stands out and who is maybe above the fold in terms of denial of claims, or is it spread pretty uniformly across the book of business?
In the report, we do have a breakdown of those plans that have sort of more than average appeals requested and more than average external reviews requested. Having more appeals requested or more external reviews requested is not necessarily a bad thing, and could be, showing that they're doing a good job outreaching to their patients. But the interim report does give a breakdown of the different plans and how many internal reviews and external reviews they've had in relation to the member months and averaging out for the larger plans.
Thank you.
Dawn, do you want to jump in?
Yes, let it be noted that I'm not a member of the committee, David, but I'd like to ask a question if I could.
Of course.
First, Nancy, thanks for the great work and the great report. The numbers are, given the size of the Commonwealth, pretty low. Do you and your staff have a sense of a underlying latent need that actually, if the communications were great and everybody were aware and so on, that there ought to be some higher number of calls to you, or do you think we're kind of hitting the need? That would bear on anything the commission should be thinking about in terms of encouraging support to you to much more outreach and awareness.
Specifically related to the hotline and calls?
To appeals.
To appeals, okay. Yeah, I mean, every year we do track how many patients come to the Office of Patient Protection to request an external review, and we relate that back to how many people have been denied an appeal, as we learn through our reporting. So in this year, we put in the report and calculated that sort of 12% of the people who've been denied an appeal at their health insurance company, and it was denied because of medical necessity, came to us. So that's 12%. It's a little bit higher than in previous years, but again, it could be higher. And so we try to engage in as much outreach as we can. And we also work with the health insurance companies to make sure, that they are providing good notice and accurate notice and listing everything as they should in their notices to consumers. So we try to do that work every day. It's really hard to say what the right number should be because we don't know what happens to that 88%. We don't know if they choose another service or they pay for it out of pocket. It's hard to sort of figure what the other case is there, but we always try to outreach as much as we can. And that is something that I'm hoping to do more of in 2022.
I'm just going to jump in then, Marty. I'm going to turn to you. So it seems like we're, thankfully, we didn't observe very many things related to COVID in terms of, people needing help during COVID. And in fact, the plans were actually sort of looser it seems like the plans were looser with many of the rules during COVID. Are you observing that the plans are now tightening up again on the rules? Like, is that how you interpret some of the recent trends that were going back up because rules that have been loosened during COVID are now being tightened again?
I can't say that we can notice any trends like that. It's really difficult to see trends in OPP because it is such a small segment of the market. So I can't say we've noticed anything specific as that.
Okay. Marty.
Thanks, David. Nancy, I wanted to dig a little on the behavioral health appeals. Could you just give us a sense of, are those sort of treatment options? Are they parity issues? Is it specialized, is it medication, or is it specialized sort of residential treatment that you're seeing appeals on?
So yeah, out of the 17, I'm just looking it up, out of the 17 behavioral health external reviews in 2020, 9 of them were for residential mental health care. So that is, over half were for residential mental health care. These are all denied because of lack of medical necessity, according to the health plan. So 9 were for residential mental health care. There were 4 eligible requests related to substance use disorders, all of which were for residential or inpatient substance use disorder treatment. So the vast majority are for those residential programs.
Thanks, that's helpful.
And mostly for mental health rather than substance use disorder.
Thank you.
Other comments from commissioners, any commissioners for Nancy? I say any, that is, you don't have to be on, of course, the MOAT committee to care about the OPP. Nancy, thank you very much.
Thank you.
David, shall I turn it back over to you to talk about the out-of-pocket spending for maternity care?
Great. Yes, thank you. And thank you, Nancy. Nancy leads a small but mighty team at the HPC and really does incredible work on behalf of the consumers and residents of the state. So we thank you. We're going to shift gears now and go to our role as a researcher and reporter, using data to uncover opportunities and trends in healthcare spending. And so I'm going to turn it over to Sasha Albert from our research and cost trends team, who's going to lead us through the next 2 agenda items, but starting first with a preview of some upcoming data points issues. So Sasha, I will turn it over to you.
Thank you, Director Seltz, and good morning, commissioners. I'm pleased to be presenting highlights and a preview of our upcoming DataPoints publication on out-of-pocket costs associated with pregnancy, delivery, and postpartum care in the Commonwealth. And before I begin, I'd just like to thank our 2021 Summer Fellow, Gray Babs, who conducted these analyses and whose work I'm glad to be sharing today. So we'll be referring here to the full scope of pregnancy, delivery, and postpartum care as birthing episodes. And nationally, out-of-pocket spending on birthing episodes for patients with employer-sponsored insurance increased by almost 50% from 2008 to 2015, with growth driven mainly by increased spending on deductibles. High out-of-pocket spending associated with spending on deductibles is a concern in Massachusetts as well, because enrollment in high-deductible health plans has risen in recent years. This is especially salient because healthcare affordability is a continuing challenge in Massachusetts, as commercial premiums and cost sharing continue to grow more quickly than wages. The HPC's previous work has found that average out-of-pocket spending on all types of services for commercially insured residents increased by 20% just from 2015 to 2017. And we've also consistently found wide variation in spending for birthing episodes, as well as growth in spending over time. So in today's presentation, we bring these areas of work together to investigate out-of-pocket spending specifically for birthing episodes in the Commonwealth. This work uses the all-payer claims database, including the 5 largest commercial payers in Massachusetts, and captures prenatal, delivery, and postpartum care for residents who gave birth in 2016, 2017, and 2018. On the next slide, our first finding is that out-of-pocket spending for birthing episodes is growing more quickly than the total cost of care. On the left-hand side, we see average total spending for birthing episodes from 2016 to 2018. And this total spending increased by 4% over those 3 years. This is in contrast with the graph on the right, which shows average out-of-pocket spending for birthing episodes. Out-of-pocket spending increased by 23% over the same 3 years. We also find that out-of-pocket costs represent a growing share of birthing episode spending. Out-of-pocket costs accounted for 5.3% of the total cost of care in 2016 and 6.3% of the total cost of care in 2018. On the next slide, we see that similar to national findings, we found that rising out-of-pocket spending for birthing episodes in Massachusetts can be attributed mainly to increased spending on deductibles. The topmost line in the graph shows total average out-of-pocket spending for birthing episodes from 2016 to 2018. This is the same trend that we saw as a bar graph on the previous slide. In the lines below, total out-of-pocket spending is broken out into deductibles, copays, and coinsurance. And we see that deductibles in the orange line make up the largest and fastest growing portion of out-of-pocket spending, and that growth in spending on deductibles is roughly parallel to out-of-pocket spending growth overall. Spending on copays and coinsurance are the 2 lines at the bottom, and growth in those components of cost sharing has not been as steep. So given these trends, we investigated what might be driving increased out-of-pocket spending for birthing episodes. And on the next slide, we first explored out-of-pocket costs by hospital cohort, comparing births in academic medical centers, community hospitals, and teaching hospitals. Deliveries at all hospital cohorts were associated with rising out-of-pocket costs from 2016 to 2018. But as shown in these 3 bar graphs, there was no meaningful variation in the size of out-of-pocket costs or the growth rate in out-of-pocket costs across these different types of hospitals. We also looked at out-of-pocket costs for vaginal and cesarean deliveries, and similar to the hospital cohort findings, we found growth in out-of-pocket spending over time for both delivery types, but no real differences in the size of out-of-pocket costs or growth trends between delivery types. By contrast, we found that the size of patients' employers is a strong predictor of out-of-pocket spending for this scope of care. The next slide shows out-of-pocket costs for birthing episodes by patient employer size. The topmost line is patients with non-group insurance coverage, followed by patients working at small employers of 50 to 100 employees, and then medium employers of 51 to 500 employees, and then with large employers with 501 employees or more at the bottom. Here we see that not only do patients with non-group coverage and those with smaller employers consistently face the largest out-of-pocket costs for birthing episodes in all 3 years, we also see that those patients have the fastest growing out-of-pocket costs. Out-of-pocket costs for birthing episodes for patients with non-group coverage grew by 41% from 2016 to 2018, which is a stark contrast with 12% growth at the largest employers. Deductible spending was also highest among patients with non-group coverage and patients employed at smaller employers, reflecting higher rates of high deductible health plan enrollment at smaller employers. Individuals with non-group coverage spent an average of about $1,200 on just their deductibles in 2018, and individuals with small employers spent an average of about $1,300 on their deductibles, which is in contrast to patients with the largest employers who spent about $900 out of pocket in total, copays, coinsurance, and deductibles combined. So these findings suggest that variation in out-of-pocket costs for this scope of care is driven by variation in insurance benefits, and in particular by differences in the types of insurance coverage that employers of different sizes are able to offer, rather than any variation in care delivery. On the next slide, we see that high out-of-pocket costs for birthing episodes can have some real affordability implications for Massachusetts residents. Each orange bar represents average out-of-pocket costs for birthing episodes over the 3 years of 2016 to 2018 for patients living in different community income deciles, with decile 1 on the left being the lowest income communities and decile 10 on the right being the highest income communities. And although average out-of-pocket costs for birthing episodes vary a bit, we don't see any real patterns in how much patients pay out of pocket by income. However, the blue dots show that there are some real affordability implications to these costs. The dots indicate the share of median community income that the out-of-pocket costs associated with birthing episodes represent. And for the lowest income residents, out-of-pocket costs for birthing episodes alone can take up almost 3% of their annual income. So to wrap up on the next slide, we find that commercially insured patients, especially those employed at smaller employers, are bearing a growing share of the cost of pregnancy, delivery, and postpartum care in the form of rising out-of-pocket costs. This trend is driven by spending on deductibles, which reflects growth in high-deductible health plan enrollment, as health insurance premiums have become increasingly unaffordable for residents. It also reflects affordability challenges for smaller employers who are likely to offer less generous health insurance in an effort to control the growing cost of providing coverage to their employees. In addition to these general affordability implications, our findings also raise equity concerns. High out-of-pocket spending is particularly burdensome for low-income residents who are also disproportionately likely to forego needed care due to cost. Additionally, birthing people of color continue to experience disproportionately high rates of perinatal morbidity in Massachusetts, which can come with its own significant financial costs over and above any out-of-pocket costs associated with prenatal, delivery, and postpartum care. Lastly, our finding that variation in out-of-pocket costs is mainly associated with the size of patients' employers indicates that solutions to rising out-of-pocket costs for this scope of care are likely to be found in insurance design rather than in changing how care is delivered. Thank you very much.
Thank you. Thank you, Sasha. Let me open it up for comments. Patty, yeah.
So I think one thing that's hard to measure is that as employers increasingly offer higher deductible programs, they are subsidizing a portion of that cost through a health reimbursement account or allowing employees to enroll in an HSA. So I think the data that HPC has available to it is only going to look at the insurance claim and not maybe seeing the impact of that other subsidy that may be there. Do people understand what I'm saying? But I still don't disagree with the findings that Sasha is showing us. If you're a non-group person, you're just looking for the cheapest coverage out there, and it's an affordability issue just for the premium. Larger employers, I think, are showing that lower deductible because employees have a choice of plans they can enroll in each year, and often pregnancy is planned, not always, but people can choose a richer program that year where they know that they're going to have a child. I think one of the things from insurance plan design that employers can be looking at is providing an incentive or a higher level of coverage for more efficient, cost-efficient, higher quality hospitals in terms of delivery, where their overall cost as the employer would be limited, but the employee would be getting a higher benefit level within the system.
Yeah, thank you. Yeah, these are all helpful and useful comments on health savings accounts. I would note, we're aware that we just cannot measure contributions to those.
Yeah.
Yeah, exactly. But the Kaiser Family Foundation, I believe, has put out some work finding that the smallest employers are also the least likely to offer health savings accounts.
Absolutely. Yeah.
And that health savings accounts disproportionately benefit higher earning workers because they have more pre-tax income to put away for their future healthcare costs. So I think, despite that sort of gap in our data, I think the trends are all pointing in the same direction.
Agreed.
Ron?
I was going to mention the HSA as well. And I'm sure that higher income individuals are in a much better position to take advantage of an HSA, for example, than someone that's not in a high income area. But on another topic, does ICHRA come into play? And do you see a change in the number of firms that are taking advantage of ICHRA, especially firms of around 100, approximately 100 individuals, because that becomes very attractive for the firm and can be pretty negative to the employee in terms of coverage. I was just wondering if we looked at any of that data in looking at this.
I don't think I'm familiar with that acronym.
Now you want me to say what the acronym is. It's a program designed where an employer can allocate, let's say, $1 for every employee for healthcare, and they can go on the national database and they can choose their own coverage. In Massachusetts, you go on the Massachusetts site, right? And they can choose their own coverage, and it's the dollar that's paid for by the corporation, which would be paid through an HRA, and that's something that companies are taking advantage of, especially if they're concerned that a particular employee may end up with a condition, their rates rise. So if they take an ICHRA approach, then they can limit what they're paying for healthcare, and then it becomes a responsibility of the employee. And I've seen a lot of companies now are starting to look at that. And I was just wondering if that was something you folks were able to look at.
Yeah, no, that's a really good point. We haven't looked into that so far, but we can certainly plan to.
Thank you.
On the issue of the cost sharing and all, a few years ago when I was on the Harvard Benefits Committee, we tried to buy a maternity policy that said, if it's a low risk birth and you go to the local hospital, you have no cost sharing. But if it's low risk and you want to go to the tertiary hospital, then you have to pay cost sharing. Except if it's a high risk birth, then you can go to the tertiary hospital with no cost sharing because that's where we want you in that circumstance. And we were told that the insurers didn't know how to design a policy like that. So, and that always has struck with me as an example of like poor insurance design. I don't know if that's true or not, or, the whole thing is made up or whatever, but that's always struck me as an example of poor insurance design, because if someone's pregnant, they need to deliver in a hospital. So like imposing the deductible there makes no sense, just sort of a financial penalty. But it does make sense to say, look, if you don't need to be at the fancy hospital, then you should pay more. If you want to go there, that's fine, but you should pay more for it.
Yeah, I think I agree. I think that's a challenging design to implement because the causality is a little difficult. I mean, I think some people will know in advance that they'll have high risk pregnancies, but certainly not everyone will know that in advance. And if you have to change insurance coverage midway through, I'm not sure if that would help address these issues or not.
Yeah, I mean, we were trying to get it done in real time, like, okay, we learn, it's now, February, you're pregnant, okay, fine. And then in April, we learn it's a high risk pregnancy, boom, then it resets then.
Mm-hmm. Yeah, that's certainly a thorny design.
All right, thank you. David Seltz, shall we?
I think we can, thank you. I think we can keep moving, Sasha, onto the next topic.
Absolutely. Thank you very much. So in the next segment of the presentation, I'll be sharing final findings and recommendations from our report to the legislature on children with medical complexity in the Commonwealth. So this presentation is a follow-up to our presentation of initial findings from October's committee meetings. So I'll be briefly revisiting those initial findings, as well as sharing a few additional findings and our recommendations that will be published in our full report. And again, I'd like to thank my colleagues on the research team, without whom this work would not have been possible, especially Justin Keel, Leiden Marcelat, and Lauren Nasuti. So to better understand the landscape of children with medical complexity in Massachusetts, the legislature has charged the Health Policy Commission with estimating the number of children with medical complexity in Massachusetts, their demographics, diagnoses, health coverage, access to and utilization of healthcare, associated costs, and recommendations for ongoing data collection and reporting. The next slide has a little bit of information about our report. Children with medical complexity are a high-need population with significant use of health and social services. The health system is not always set up to adequately support them. For our report, the Health Policy Commission investigated demographics, health coverage, health service utilization, and spending, and also met with stakeholders to understand issues of care not measurable in administrative data. Children with medical complexity, in general, are characterized, on the next slide, by having serious, chronic, and often multiple medical, behavioral, or developmental conditions, including functional limitations, high health service needs, and high utilization. And they often require surgery or inpatient care and often rely on durable medical equipment, supplies, and medical technology. As we shared in October, the Health Policy Commission used diagnosis, spending, and utilization criteria to identify children with medical complexity in our hospital discharge and claims data. We estimate that as of 2018, children with medical complexity represented 32% of Massachusetts residents ages 1 to 21 with inpatient hospital utilization. Children with medical complexity represented 4.5% of the commercial population ages 1 to 21, and 6.4% of beneficiaries ages 1 to 21 enrolled in Mass Health MCO or ACO plans. So before I share a few additional findings from our final report, I'd like to give a quick refresher on key findings from our prior presentation. On demographics, we found similar rates of children with medical complexity across all demographic groups and regions of Massachusetts. In other words, children with medical complexity are all types of children and live in all parts of the Commonwealth. On utilization, children with medical complexity who are hospitalized have nearly double the length of inpatient stay of children without medical complexity, with average stays of 6.5 days compared to 3.6 days among children without medical complexity. In 2018, 36% of children with medical complexity who received inpatient care were cared for at Boston Children's Hospital. We also found that children with medical complexity have almost twice as many ED visits per person on average than children without medical complexity. On spending, annual commercial medical spending for children with medical complexity is 18 times that of children without medical complexity. And annual spending for children with medical complexity enrolled in Mass Health MCO or ACO plans is just about 16 times that of children without medical complexity. Additionally, 65% of children with medical complexity with primary Mass Health MCO or ACO coverage also receive services covered on a secondary fee-for-service basis by Mass Health, most commonly services such as personal care services, non-emergency transportation, or occupational therapy. In addition to these findings, we have a few further findings that will be included in our final report on the next slide. These are on areas such as hospital utilization and on the transition from pediatric to adult care for young adults with medical complexity. First, we find that children with medical complexity spend longer in the ED and are more likely to experience ED boarding than children without medical complexity. That is, they're more likely to stay in the ED for 12 hours or longer. In 2018, 15% of ED visits for children with medical complexity lasted 12 hours or longer, as shown in the yellow and blue segments of the left-hand pie chart, compared to 6% of visits for children without medical complexity. Often, children with medical complexity visited the ED for behavioral issues such as depression, as well as acute physical issues such as abdominal pain, fever, cough, or upper respiratory infection. On the next slide, we see that among pediatric patients with at least one hospital admission, children with medical complexity are more likely than children without medical complexity to be readmitted to the hospital within 30 days of discharge. In 2018, 45% of hospital discharges among patients ages 1 to 21 were for children with medical complexity, as shown in the orange at the bottom of the bars, but children with medical complexity had 80% of readmissions. Lastly, one additional area that we were charged with investigating is the transition out of pediatric care and to adult care for young adults with complex medical needs. It can be difficult to estimate the exact number of children with medical complexity who transition to adult care each year because pediatric to adult care transitions for children with medical complexity do not occur all at once. Transitioning to adult care takes place gradually between the ages of 18 and 22. The Health Policy Commission estimates that as of 2018, about 20% of Massachusetts children with medical complexity were ages 18 to 21 and likely in the process of transitioning to adult care. care transitions include several challenges. First, different public programs can have different age cutoffs for eligibility, and while aging out of different types of public support in a staggered way is preferable to a single eligibility cliff, it can create an extended period when a young adult's provider network is in flux. Another challenge is adequate access to adult providers who are equipped to care for patients with pediatric onset chronic conditions. And lastly, self-management may be a challenging learning curve for some young adults with complex medical needs, especially if the transition to adult care takes place at the same time as young adults become more independent in other ways, including the transition to living more independently or to workplaces or colleges that are not always equipped to support employees or students with chronic health needs. We'll wrap up with our recommendations. The legislature has charged the Health Policy Commission with developing recommendations specifically related to data collection and reporting to improve care for children with medical complexity in the Commonwealth. To support care coordination, we recommend that Massachusetts consider creating a central database on children receiving multiple public services to facilitate information sharing, coordination, and service integration, including exploring data needs and appropriate care coordination structures. To support measurement, we recommend that the Commonwealth track and report on measures related to children with medical complexity to ensure their timely access to needed care, including distance to care, wait times, and regional availability of primary and specialty providers. And we recommend identifying a dedicated hub for this work. So our full report should be released in the coming week or so, and I would be happy to answer any questions from the committee about this work. Thank you.
Sasha, let me start off on this one. So I'm glad you left this slide up. The first of those points on the left is really super important. And I've been sort of musing in my mind for a while and talking with other folks for a while about the idea of finding people, and starting with kids is great, who have very high needs and are in many, many systems run by the Commonwealth or private providers, and trying to at least gather some central information from medical records to potentially school records to criminal justice records to all sorts of information, so we can have a 360-degree look at it and so on. And really figure out what these people, kids, adults, so on, need for that. So I really think that's terrific. The Congress, of course, recently passed the infrastructure bill, the US Congress, which has a lot of money for infrastructure, including amongst including broadband and other kinds of IT infrastructure. And I wonder whether we couldn't go further in this recommendation and think about, is there a way the Commonwealth could use some infrastructure funds to try and set something like this up so that we can try and link across these different data systems and pull something together? Because ordinarily, I mean, it's not a ton of money, but it might be more money than we could easily allocate. But with the infrastructure funds, there may be a way to do that, to tie this into our use of infrastructure funds that may make it be really easy to do. So I think it would be worthwhile checking that out here.
Thank you.
Thank you, Commissioner. Yeah, we will follow up on that and see what we can learn.
Let me see if any of my fellow commissioners or anyone has any other questions for Sasha on this. Sasha, it seems that you and I spoke for everybody, and everybody clearly agrees with everything that was said. So the record shall reflect that there was universal agreement on all of those matters. Thank you.
Thank you very much.
Okay, I think we should turn to the performance improvement plan process update. David, back to you.
Great. Two quick housekeeping things. So Sasha just presented on two pieces of work, the data points on out-of-pocket spending for maternity care and the children with medical complexity. That first one, the data points, we do expect to release in the coming weeks. We will let people know through our newsletter when that is posted and available online. And the second report, Children with Medical Complexities, we do plan to post on our website today. So for those interested in seeing that final report, please check out our website, and we will again also promote that through our HPC info. I neglected to introduce this person at the beginning of the meeting, but do want to recognize the chair of the HPC, Stuart Altman, who has been here in the Zoom room the entire meeting. Thank you, Chair Altman, for joining us today.
Oh, I wouldn't miss it. And it's a pleasure to hear these reports.
And we were also joined earlier by Commissioner Berwick, who I think did have to step away with a conflict, but wanted to recognize the other commissioners who are here today. So we're going to transition now to really have a follow-on conversation to our last board meeting. At the last board meeting, the HPC board voted unanimously to require our first performance improvement plan from Mass General Brigham. And so today, what we hope to do is provide an overview for the commissioners and the public who are interested in this process about what happens next. And so to really walk through the different process options and to get your answer your questions, I'm going to turn it over to Kara Vidal, who leads our performance improvement plan review process. So Kara, take it away.
Thank you. Thank you very much. Good morning, commissioners. So after last month's vote, the HPC sent a notice of a requirement to file a PIP to MGB. That notice is available on the HPC's website, as are the slides from the public portion of that January 25th board meeting. So that means that MGB now has until March 13th to file a proposed PIP, a waiver request, or an extension request. Any of those documents would also be made available on the HPC website. So the next steps for the HPC depend on which of the three filing types MGB submits. If MGB files a proposed PIP, the board will have to vote on whether to approve the proposal, and we'll talk a little bit more about that in a few slides. But at a high level, if you approve the PIP, MGB will begin implementing their proposal. If you do not approve the PIP, MGB will have 30 days to resubmit. And I do want to call attention to a really important feature of our process here, which is that the regulation explicitly encourages MGB to consult with the HPC in the development of their PIP proposal. That gives us an opportunity to answer questions or provide feedback, and that can help MGB ensure that they've met the required criteria for a PIP and have developed a proposal that the board can approve. I won't read the rest of the bullets here on the different timing and processes for waiver requests or an extension requests, other than to say that the only filing type that does not need to come before the board for a vote is a request for an extension of up to 45 days, which can be reviewed and adjudicated directly by Director Seltz. Okay, so on the next slide, according to our regulation, the notice of a requirement to file a PIP must include not only the process and timing details that we just discussed, but also the HPC's basis for requiring a PIP. That basis was presented publicly at the January board meeting and was summarized in MGB's notice in the form of the 4 bullets that you can see here on this slide. And I will recap these quickly, but before I do, I just do want to remind you, commissioners, that this summary information reflects the balancing test that the HPC used to determine what of the confidential information you reviewed in executive session would be made public. So to the extent you have comments or questions on this slide, please just be aware of those confidentiality considerations. Okay, so with that caution out of the way, the HPC's basis for requiring a PIP can be summarized as follows. MGB has high baseline spending levels and high growth, which resulted in cumulative commercial impact of $293 million from 2014 to 2019. MGB acknowledged that this spending growth was not driven by a worsening of the health status of its primary care patients. The HPC observed above benchmark spending growth over multiple payers and multiple years, including in alternative payment method contracts. MGB's hospital and physician prices are higher than nearly all other providers in the Commonwealth, and price and mix were bigger drivers of spending than utilization. And finally, MGB stated that its primary strategies for controlling growth were continuations of its existing efforts, which have not been sufficient to restrain spending to date. The following slides lay out the general process that any entity required to file a PIP, including MGB, would follow. So turning first to the question of how the HPC will assess a proposed PIP. Process-wise, once a PIP proposal has been filed, commissioners will be provided with a PIP proposal, staff analysis of the PIP proposal, and any additional information provided by MGB. You'll have an opportunity to provide comments or recommendations regarding the proposal as well. And as I mentioned, our regulation informs and envision a process in which we can ask questions or provide feedback before the vote on the proposal itself, again, with that goal of assisting MGB in developing a proposal that meets the standard for approval. Once the HPC completes that back and forth, the board will vote on whether to approve a PIP proposal. And per our regulation, the board shall approve a proposal if it meets the regulatory requirements, and if the board determines that it is reasonably likely to address the underlying causes of the entity's cost growth, and that the entity will be capable of successfully implementing the PIP. And in making that determination, there are several factors included in our regulation for consideration, and those include the evidence base for the proposed interventions, the scope and likelihood of potential savings, and their impact on the Commonwealth's ability to meet the benchmark, sustainability concerns, the potential for negative consequences, and any other factor that the HPC determines are in the public interest. So the instructions and forms that must be used to file a PIP proposal are available on the HPC's website. Any final PIP proposal shall be a public record and will be posted on our website after the board has voted. The forms include contact information forms, the proposal form itself, which would include narrative responses to the relative questions, and the affidavit of truthfulness forms. An entity can also submit supporting documentation and evidence as attachments, and they can include non-public information in those attachments, which the HPC can protect from disclosure. Although the entity must identify which of the information included therein is non-public. On the next slide, you'll see that the PIP proposal form includes 10 sections. They're laid out here on this slide. I won't read them all. I will highlight only a few here. The first is that in section 2, the entity must define a specific quantitative savings target. In section 4, the entity must describe the strategies and interventions that it proposes to undertake and how those strategies will translate into savings in total healthcare expenditures. In section 5, the entity must identify the measures that it will use to track its progress. And in section 8, the entity must summarize its plans for maintaining the savings after PIP implementation has ended. And then I think we have just one more slide here, which I'll walk through before I pause and open it up for questions or comments. Okay, so there are also forms on our website for requesting a waiver or an extension. A waiver request must include a justification for the request along with new supporting data and evidence. And our regulation does include a set of criteria that the HPC would consider when determining whether to approve a waiver request. These include familiar factors such as cost, price, utilization trends over time, ongoing strategies for cost containment, among others. An extension requests also require a justification, which the HPC will consider when determining whether an extension is necessary. And as I said previously, those forms would also be made available on our website. Our regulation does also include the potential for a fine, but only in the case of non-compliance, and it's really meant to be used only as a last resort. So that is the relatively quick summary of the next steps in the process here, and happy to answer any questions I can.
So I suspect we have a number of comments. Marty, I'll jump in at some point, but Marty, let me start off with you.
Yeah, thank you, Kara. This is helpful. Could you just go over what the criteria would be for granting a waiver request?
Sure, absolutely. There are specific factors that the HPC would consider before approving a waiver request. Those factors are not identical to, but very similar to the factors, the regulatory factors that we looked at in the initial stage of the PIP's process to determine whether or not a PIP was warranted. So I believe those are specifically costs, price, and utilization trends of the entity over time, and any demonstrated improvements to reduce health status adjusted TME, ongoing strategies or investments that the PIP entity is implementing to improve future long-term efficiency and reduce cost growth, whether the factors that led to increased costs for the PIP entity can reasonably be considered to be unanticipated or outside of its control, the overall financial condition of the PIP entity, any significant difference between the growth rate of potential growth state product and the growth rate of actual growth state product. So, whether the benchmark was maybe sort of not lining up as anticipated, and then any other factor that the commission considers relevant. So you'll see that those factors are very similar, although not identical to what the board looked at in the early stage of this process.
Yeah, that was my reaction, but thanks.
So Kara, I want to play out what I think would be a bad scenario and something I hope we can avoid. So I think that, so MGB's argument, which they made many times, is that by shifting to lower cost settings, they'll save money. By moving people from MGH out to Woburn and so on, they'll save money. And we as a commission don't deny that specific transaction, that specific movement will save money. But what we say is a couple of other things. One is that empty bed at MGH will now get filled by someone else, and that will cost money. And that the people seen at Woburn will get many more services, and it's not clear they're lacking on services now, so those many more services will add to expense. And that those people out in Woburn will now come into downtown hospitals, MGB more, and that'll add to expense. So all of those things, but here's what worries me. What worries me is that we're going to be stuck in the infinite loop where the screen just displays that circle going round and round and round, where MGB says, no, this is really going to save money. And we say, no, you're not telling us what we want to hear. And then everybody's frustrated rather than, so I'm trying to think of what we can do to help avoid that circumstance where they say X, we say, yes, we agree with X, but you've forgotten about Y, Z, W, A, B, C, all the way up to double K, and all of those are adding to expense. And so, so how is it, and this may be more maybe for Stuart and Marty and David Seltz, in addition to you, Kara, how is it that we avoid getting stuck in that infinite loop where they say our plan is X, and we say, yeah, but we've already said why we don't believe that X is a plan. So what do you want us to do? Do you want us to vote no on what on earth can we do to avoid that? So that's a question that I don't know if anyone wants to tackle that.
Well, let me, I think you got it right. That's been the scenario in our discussions with them. It is a loop. And as Kara has pointed out, we have the option of saying, no, your report is inadequate. And this is the reason why, or these are the reasons why. At some point, I mean, if they just ignore our comment, I mean, we're pretty clear on why they're not talking about the complete picture, which you laid out very well. So our option is to say this is not an acceptable report or not an acceptable plan to address your spending problem. And then we follow the scenario that Carol laid out. I don't know any other alternatives. But I think you have it right. It is a potential, real potential.
I'll add just 2 quick points. One, Commissioner Cutler, to the point around impacts on broader healthcare spending from some of these dynamics, even if they may result in some savings for MGB patients. And the dynamics you laid out are absolutely clear and were laid out exhaustively in our comment. One note there is our regulatory factors explicitly refer to the need. One of the considerations for the commission is, does the plan, what is the impact of the plan on the benchmark, on total healthcare spending? So that is an important factor that we wanted to highlight today, that the plan and the board does have the right and responsibility to review a plan and think about its impact on total healthcare spending on the benchmark. And that's consistent with our role in many circumstances about thinking about total healthcare expenditures in the Commonwealth. So I think that is an important point to make. And to reiterate another point that Kara made, which is that our regulation, and I think building from the statute, contemplates the potential for a little bit of back and forth and collaboration prior to them filing a performance improvement plan. And so we stand ready to engage in that process, and that may be the path where we're able to articulate what our process is, what the factors are that the board will be considering, such that they can file a plan that will have a higher likelihood of approval.
I think to the extent we can, David Seltz, to the extent we can encourage that, and Stuart was, I think, thinking along similar lines, that seems like it would be beneficial to all parties. It doesn't serve us and it doesn't serve them well to get caught in that infinite loop.
Absolutely. And David Seltz and I have been talking about us meeting with them. We would like to avoid that loop discussion, and in our discussions with them, they are not. They've been forthcoming in the sense of claiming that they want to be responsive, but their response has been inadequate in the sense that they have basically said what you said they were going to say. And it's just not the complete picture. And they must know it. I mean, they're smart enough to know that that their activities are generating higher spending. And as a matter of fact, they've said that in talking to other groups on how they're going to increase revenues. So we will try.
Yeah. As I say, I'm not sure I have great thoughts.
David, we welcome your help in trying to make them understand it.
I wish I had great thoughts because I would feel better, but I don't. I'm not sure I do. But
all right.
Let me call on other commissioners as they to offer comments or thoughts.
Commissioner, if I could offer just one more reflection that I think speaks to the point that was just made. The performance improvement plan is a tool to try to drive towards a positive outcome for the residents of the Commonwealth. We want to have a successful performance improvement plan. That is the goal. The goal is to have a plan that will actually make a meaningful difference in improving affordability of care. That is the outcome that I hope and expect that both the HPC and MGB can find common ground to work together on.
Very good. So I don't see any other commissioners with particular who are raising their literal or figurative hands at the moment.
Yeah, David, I think we all share your concern that we've got to find some endpoint here that makes sense for both parties.
Yeah. Yeah, and for the people of the Commonwealth, it's essential that, of course, we do the utmost that we can to make that happen.
Yeah.
I think then what we will do, David Seltz, unless you have any other.
I have one final agenda item
Okay.
that was kind of tacked on to the end of this presentation. So just want to preview for all commissioners that our next public meeting is going to be our annual hearing on the modification of the healthcare cost growth benchmark. And this is a new year and a unique year because we have now reached year 10 of this benchmark modification process that was originally set forth in Chapter 224. So as a very brief reminder, in years 1 through 5, the healthcare cost growth benchmark was established by law at the annual determination of potential gross state product, which is a metric trying to measure the long-term estimated growth in the state's economy. And that has been at 3.6%, was established at 3.6% in law in the first year and has been reviewed every year by the administration and the legislature and continues to be set at 3.6%. So for the first 5 years, this board had no discretion to modify the benchmark to any number except PGSP. In the next 5 years, we did have a limited authority to modify the benchmark. The default rate for the benchmark was PGSP minus 0.5 percentage point or 3.1%. And that was what we have set it at every year for those 5 years. The board had the authority to move the benchmark back up to any number between 3.1 and 3.6, subject to legislative review. The board opted not to do that and kept it at 3.1 this time period. We are now entering the 10th year and the authority changes again. So now for the next 10 years, the benchmark, the default rate for the benchmark is at PGSP. So that is again 3.6%. However, the HPC board can modify to any amount above or below that default rate. And if they choose and the board elects to do so with a vote, there is a legislative review process that occurs afterwards. So this is a new and unique year for us in determining the benchmark. It is also going to be a unique year in that we will have the CHIA annual report soon, which will show our performance against the benchmark between 2019 and 2020. So the pandemic year, we will see the impact of the pandemic on total healthcare expenditure growth and our benchmark performance. That report is planned to come out in mid-March. So on the next slide, you can see that we are planning our hearing, which we hold every year in collaboration and partnership with the Joint Committee on Healthcare Financing. It will occur on Wednesday, March 16th from 12 to 3. We are preparing this hearing as in years past. We plan to perhaps invite a guest speaker, an expert who can speak to some of the national trends. We will have our own presentation of data and information. We will have an opportunity for dialogue with the Joint Committee, and we will also invite stakeholders to provide testimony to the board on the establishment of the benchmark. The board will not vote to establish the benchmark on March 16th. This is really the information gathering stage. We will then meet in April as a full board to determine where to set the benchmark for calendar year 2023. So the hearing is upcoming. We're planning it, look forward to gathering this information. And really at this stage, open to questions about this process. We'll go over this again at the hearing. But if there are any pieces of information or suggestions or ideas for the hearing that you'd like to share with us as we plan this, always welcome. And so I will pause there to see if there's any questions or comments on our next big event.
David, I'm glad you mentioned the idea of bringing in an outside speaker who can speak specifically about what's going on in the national trends. I think for purposes of this discussion, given that we have broader authority, I think it's more important than ever that we look at us in relationship, in comparison to the national trends in two ways. One is that our delivery systems are subjected to much of the same pressures that are going on in the rest of the country. And as you know, I've been pretty vocal and very concerned about the growing gap between commercial insurance premiums and Medicare. And that when we average them together, we might get a number that isn't too as great, but that the gap leads to higher and higher commercial rates, which has a real impact on affordability, as you have and the team has pointed out. So I would encourage you and David Axel Arbach to give us the latest on what's going on nationally. And the second area, which I don't know how we deal with it, but we have to deal with it, is to what extent the pandemic has so influenced for either a limited period or permanently utilization and spending trends. We're going to have to disentangle that and try to anticipate what the future lies with respect to the pandemic. And here we're going to need a crystal ball that I don't know anybody who has figured out how to do that, but it's something we need to deal with. So I think we have our work cut out for us.
Mm-hmm.
I don't know if
there are some national data on what's been happening post pandemic that we can tap into.
Well, I wish we were at post-pandemic.
Yeah, or at least post-immediate, up through like.
I do know that part,
yeah.
But we also have to anticipate what the future is going to look like.
Yeah.
But you're right, sure.
Yeah, I would just also add that we are facing a second pandemic on the behavioral health side as a result of COVID, and which will impact costs.
Mm-hmm.
Yes.
Chair Altman, your comments are very well taken. This will be, a complicated conversation because we will both be looking backwards to try to understand the impact of the pandemic, and also looking forwards into the future when considering where to set the benchmark for calendar year 2023. So we're both going to be looking backwards and forwards at the same time with a lot of uncertainty and moving data. So I look forward to your guidance and leadership to help us navigate through that. That is the last agenda item that we have on the committee agenda for today. So Commissioner Cutler, absent any other questions, comments, feedback, we can adjourn this meeting and we can take a slight break.
That sounds great. And does anyone have anything they wish to add at the end before we take a break? If not, the next meeting will start promptly at 11 o'clock.
Thank you. We'll return to the Zoom room as well.
Thank you to everyone.
Guys, I need to sign off. Just let me know.
Okay, are we good to go?
Good morning,
Colleen,
we're
do you think?
live.
Good morning, thank you. Welcome, everybody, to the CDT committee. We have a great agenda today, and we're looking forward to getting started. We're waiting for one additional commissioner before we do the minutes. So Colleen, if it makes sense, what I'd like to do is move directly into the mass up presentation and then swing back to the minutes at the conclusion. So, and I'm going to turn it over in a moment to Kelly Hall to do the introduction of the program. But I need to say that given our preliminary discussions earlier this week with regards to the Mass Up program, that this program has had tremendous results and has done tremendous work in partnering with the community to ensure that services are relevant, services make a difference, and services have an impact. So with that in mind, Kelly, let me turn it over to you to do the introductions.
Thank you so much, Commissioner Blakeney, and good morning to the other commissioners. As we said, we do have a busy agenda for us, and with that wonderful introduction, I don't feel like I should waste too much more time with additional commentary, other than to say, you know, as we think about pursuing our three goals of affordability, equity, and cost containment, it really is becoming increasingly clear that addressing the upstream causes of poor health outcomes are absolutely critical to achieving all three. And that we are, as Commissioner Blakeney noted, that going to be a lot more successful if we do that work in partnership with communities. Today, we are welcoming one of the awardees from our Mass Up investment program to share their experience of that work. And to introduce them, let me turn it over to Caroline Knuthia, who is currently managing the Mass Up program. So Caroline, let's get it started.
Great, thank you so much, Kelly. And good morning, commissioners. We are very delighted to have representatives from one of the Mass Up partnerships here today. Before I introduce them and let them tell you about all the great work they've been doing, I wanted to just quickly set the stage with a few reminders about Mass Up and where we are right now in the life cycle of the program. So let me start with a brief reminder about the Mass Up program design and goals. As you may recall, the Mass Up investment program is a 3-year program that provides up to $650,000 to 4 partnerships between healthcare provider organizations and community organizations to address a specific social determinant of health in a given community. The program is being led and resourced in collaboration by the HPC and the Department of Public Health. The core idea behind Mass Up is that the social determinants of health have a profound effect on the health of individuals and communities, and making meaningful changes in those social determinants is both critical and nearly impossible for any one organization or sector to do so alone. So Mass Up's purpose is to invest in cross-sector community partnerships that bring people and organizations together that can collectively identify how to tackle these root causes of poor health and combine all of their strengths to work on making lasting changes. A lot of this work is about relationship building between the Mass Up partnership and the community within which they work. In order to work upstream to address root causes of health inequity, a durable, sustainable partnership must be built. So the Mass Up partnerships are intentional about engaging community organizations and residents in their work and establishing a governance structure for themselves that creates equity among the participants and shared accountability for the work. Next slide, please. Thank you. I want to give you a quick snapshot of where we are in the program timeline. We are currently in month 18, halfway through the 36-month period of performance. The planning period, kicking off in September 2020, lasted 6 months, and the implementation period began March 1, 2021, and will last through August of 2023. Next slide, please. As a reminder, we are working with 4 great partnerships who have each identified upstream approaches to addressing social determinants of health to fit the needs of their community. These partnerships are the Hampshire County Food Policy Partnership, in which we are very excited to have representatives from the partnership here today to tell you more about it. I'll also be talking more about them in just a moment. The Heal Winchinen Partnership, a coalition originally focused on improving access to food insecurity, identified economic empowerment as a key driver to food access and is working to shift the narrative around poverty by increasing access to financial coaching while also promoting youth engagement as future leaders in a vibrant and inclusive town. The Cross City Coalition, which is working to coordinate municipal workforce development efforts by partnering with job training programs and local businesses to build on-ramps to good jobs in growth sectors in the cities of Chelsea and Revere. And lastly, the MassUp Springfield Partnership, which is advocating for more equitable food system reform policies and expanding community members' knowledge of and access to food assistance programs, particularly for Black and Latinx communities in specific neighborhoods in the city of Springfield. Next slide, please. Before I introduce the Hampshire County team to give you more details, I'll just quickly remind you of some of the key aspects of their partnership and their work. This group of organizations came together under MassUp with the goal of establishing a county-wide coalition to address food insecurity, specifically by establishing a resident-driven and led food policy council. As you'll hear in a moment, this partnership has spent the past year really supporting a group of residents from across the county to come together and design the council and plan how we will work to advance equitable food policies and initiatives run by and for those who benefit from them. And I'm pleased to say that the Hampshire County Food Policy Council officially launched last month in January. So without further ado, I'd like to introduce a few key people from this partnership to share what they've accomplished and what the future holds for the newly launched council. Presenting today on behalf of the Hampshire County Food Policy Partnership is Jeff Harness, Chief Community Relations and Communications Officer at Cooley Dickinson Hospital, Caitlin Marquis, Healthy Hampshire Program Manager at the Collaborative for Educational Services, and Kia Aoki, Community Volunteer on the Food Policy Council. With that, I would like to hand it over to Jeff Harness to kick us off.
Thank you, Caroline, and good morning, everyone. It's great to see you. Wish we could do it in person, maybe next time. I first want to say that working with the Health Policy Commission staff has really been wonderful. It's been a pleasure. Everybody's very well organized, very friendly, very helpful. The communication is very clear, and we actually have a little fun along the way too. So thanks for that. I think it's really unique in state government to see a grant like this that offers so much support and flexibility. And I've worked on many over the years, but I do think this one is unique in a good way. And I think that all of us do recognize the experimental nature of this MassUp work, and that the collaboration between state government, a healthcare system, a community agency, and residents it's interesting and unique. We are learning a great deal in our work together, and I think you'll see as we present that we have created a strong foundation for our work in our community as we launch the Hampshire County Food Policy Council. We're going to start our presentation with Caitlin Marquis talking about our community, the Food Policy Council accomplishments so far and next steps. And then I'll talk a little bit about why I think this work is relevant and important from a healthcare vantage point. And then I'll turn it over to Kia Aoki to give her perspective as a resident participating in the project. So Caitlin, let me hand it off to you.
Thank you so much, Jeff, and thank you so much to all the commissioners for giving us your time and attention today. We're really excited to share a little bit about our work with you. And I'm wondering if we can go to the next slide, and I'll start us off with a little bit of background information. So really, when we're looking at the social determinants of health that we're trying to tackle with this project, there's two main areas that we're looking at. And one is food insecurity, so people's ability to access fresh, healthy, culturally appropriate food of their choice. In Hampshire County, we do have challenges with food insecurity. 1 in 10 Hampshire County residents is low income and lives more than a 20-minute walk or drive from a supermarket. So in the hill towns, walking to a supermarket isn't really an option. It's a more rural part of the county. But even in the hill towns, most folks don't even live a 20-minute drive from a supermarket. Less than a 20-minute drive. And 12 out of 19 Hampshire County towns experience low food availability. And this is based on some work that we did, some assessment work we did with the Pioneer Valley Planning Commission back in 2017. So we are clear on the fact that we have some challenges here that can lead to negative chronic disease outcomes. And let's go to the next slide. The other challenge that we really are thinking about and addressing through our approach to this work has to do with mental health. And we think of mental health as both a cause and consequence of poor food insecurity. So when folks are feeling out of control, feeling, like they don't have control over their lives, or, just having poor mental health days, right? It's really hard to access, really get the means together to access healthy food, especially when it is hard to access already. And then, not being able to access that food also can cause poor mental health, which poor mental health also is a cause and consequence of chronic disease. So we really don't think that that there should be any solution to this food insecurity challenge that doesn't take into account really people's ability to live joyful lives, to live gratifying lives, to feel some sense of self-efficacy in their lives. And so we do also have some challenges with mental health in Hampshire County. Our mental health hospitalization rate is 22% higher than the state average, and that's particularly exacerbated among Latino residents and Black residents, who have 65% and 70% higher hospitalization rates respectively. Our suicide rate is the second highest in the state. But we also know that social capital, social networks, and social support are protective factors against these poor mental health outcomes and predictors. So let's go on to the next slide. So our solution to addressing food insecurity while also thinking about mental health and self-efficacy was a food policy council. And what the food policy council does is really bring together all of these different stakeholders in Hampshire County who are concerned with the food system, how it's working, how it's serving people or not serving people, and really thinking about developing a food policy council from the place of, what I always say is, we talk about the proverbial table, and a lot of the time a bunch of professionals come together and they form a table. They say, okay, we're going to form a food policy council, and then they're all sort of looking around at each other going, but feels like there's a lot of people missing from this conversation, like the folks who, are really experiencing these negative impacts and outcomes that we're talking about are not here. So we really wanted to start from the other way around, and we can go on to the next slide here. And really try to think about, how to form a food policy council, really putting those folks who are most deeply feeling those negative impacts at the center of the design. And this idea and this intention came out of a food access assessment that we did back in 2017. That map I showed you came out of that. And this is also something that Healthy Hampshire and Cooley Dickinson partnered on. So, and this was part of the Cooley Dickinson's community benefits work and community benefits assessment. We did a little bit of a deeper dive into food insecurity. And the top recommendation coming out of that assessment, which also was something where we really tried to engage those folks who, like I said, are experiencing the most negative health outcomes and impacts. One of the top recommendations was to form this food policy council, and the idea being that the food policy council would be a container to continue holding this work and thinking about how to engage those folks in the conversation who are often left out of the conversation. So that was back in 2017, and so we got the MassUp funding. I think 2020 or 2021 is when it started. Time is hard during the pandemic, but so, it took some time really for us to identify the right funding source and the right means to bring this council together in the way that we wanted to. So we were really excited and fortunate to have this opportunity with the MassUp grant. And we can move on to the next slide. So our theory of change that we are currently operating with, and this has, changed a little bit since we started. We're sort of letting it emerge and be impacted as we go. So the idea is that we really start with sharing power. Like, what is most important? What's sort of the whole unifying factor of this project is making sure that we're sharing power between those who traditionally have it in, the ways that we often think about and talk about power, and those who traditionally don't. And we do that by cultivating self-governance, which leads to building relationships across difference, which, and I'm sorry, the text is a little bit hard to read here, but which we hope will lead to actual changes in equitable food policies and initiatives, like Caroline said, run for and by those who benefit. And the ultimate outcome of all of that really being that folks are living more joyful, more gratifying lives where they're really able to engage with these opportunities that are being created through the Food Policy Council. And next slide, please. So I mentioned how we sort of flipped the traditional model on its head. And one of the ways that we did that was we formed something called a startup circle. So the group started off using a method of governance called sociocracy that we've continued using. And the startup circle had the opportunity to choose whether they wanted to continue using sociocracy as the decision-making and governance method or not, or something else. And we really put all of the options in front of this group. They chose to continue with sociocracy. Sociocracy is a whole, that could be a whole presentation unto itself. It's a really interesting method of governance. If you are interested in learning more, you can go to sociocracyforall.org. And it operates with circles. So basically it's a non-hierarchical form of governance where a number of circles are interacting within a network to basically make shared decisions, but also the circles have their own domains of decision making. So they don't have to run up or down to make the decisions that they're making. So this startup circle basically was tasked with making the decision about what the governance structure of the Food Policy Council would look like. And so for the startup circle, it was really important to us that we populated it with folks, like I said, who are traditionally left out of this conversation, but also that geographically represent Hampshire County pretty well. So we recruited folks from Amherst, the Hill Towns, Northampton, and then on the bottom corner, there's the conveners, which are me and my colleague, Kristen, at the Collaborative for Educational Services. Andy Grant is our sociocracy coach who has been involved from the beginning. And then Talia Segoba came in later and is now, started working with the Startup Circle. They also work at the Collaborative for Educational Services. So we have a nice distribution here, both geographically and also between professionals and community members who are not holding professional positions. All of those community members are compensated and supported to the best of our ability to participate in this work as well. Next slide, please. So we recently kind of clarified our goals a little bit more. We sort of narrowed it down to wanting to engage in activities that are aligned around a mission, vision, and values. We want to work toward long-term sustainability for the council and its initiatives. We want to cultivate trust through transparency, connection, and mutual support. We want to build the capacity of the community to engage in this work. We want to develop equitable food systems and policies and equitable food system policies. So really there's the policy side of this work, and then there's sort of the initiatives, like the Food Policy Council is also interested in doing projects. So working on both levels. And a lot of our work so far has just been in setting up the structure of the council. But in the process of doing that, we've also awarded 5 mini grants to some local organizations to do work that is also kind of putting community members at the center of decision making, but doing it through actual initiatives and projects that are related to healthy food access. We've had 12 learning circles to help build the capacity of our network members. So basically over the course of this year, while we were developing this governance structure, we held monthly learning circles so that we could sort of prime folks who would want to get engaged in the network with some of the knowledge and values that was going into this work and the way that we're doing it. And then, as Caroline mentioned, we launched the Food Policy Council in January. So that was with our governance structure developed. We had our areas of focus prioritized. We had a partnership policy developed. Another word for that would be membership policy. We're just using the term partnership. And we also developed communication channels and branding and things like that. So along with our launch came a lot of accomplishments, and we're sort of now actively working on moving into the next phase of our work, which I think is what the next slide is about. Oh, so this is just our structure, shows our structure. So essentially, we decided to launch with these 4 core circles coming off of the hub. And so the way that sociocracy works is that representatives from these core circles will sort of invert and form this hub. So we have capacity building, food policy, food action, and vision. And so capacity building really focused on training, making sure people have the tools and resources they need to engage in this work. Food policy really being like capital P policy, legislation oriented, and food action being more project and initiative oriented. And then vision really focusing on just making sure the network is staying in line, moving forward, according to the vision that has been set for it. Next slide, please. So what comes next? So basically, we're working right now on expanding our network and partners. We are doing trainings. We had a sociocracy training yesterday, and we have an implicit bias training coming up in a couple of weeks. These are what we're considering sort of the 2 foundational trainings to participate in the council. But we also will likely continue doing trainings and learning circles as we go. And we're building out these circles that I just described, filling them, populating them with partners who came to our launch and had been expressing interest in getting involved in our work. We also have to identify leaders and support the leaders within the circles, to fulfill those roles. So the leaders have to be trained and supported as well. Each of those circles will have to prioritize their own strategies, what they want to work on. And then, like I said, we had made these 5 mini grants before. We still have some additional sort of discretionary funding that the Food Policy Council has control over to allocate. So we have to look at how we're going to allocate that in the next year. I think I might be turning it over to Jeff now. Yes.
Thanks, Caitlin. Yes, the next one's mine. So I'm going to talk a little bit about how I think the role of hospitals and healthcare systems continues to evolve. And I'm going to start with 4 examples. Trying to move from episodes of care to a more holistic view of people and putting patients at the center. I'm not going to claim that we're there yet, but that's the plan. We're trying to get there. Again, moving from services and programs that are fragmented and siloed towards something that's more integrated, more coordinated. And I'll show you an example on the next slide, but don't go there yet. Also creating new care models based on patient needs and preferences. And we're learning a lot about this during COVID. So preferences like care at home, urgent care centers, telemedicine, things that are a little bit newer to healthcare. And I think COVID has pushed us to think a little bit more about how we might provide care in different ways that meet people's needs. And then value-based care and population health. They're moving all of us towards innovation, and I hope greater alignment with community health and public health approaches. Focusing more resources and attention on upstream, like we're doing now through this project. Community-based solutions, I think, moves us towards better outcomes for people and for communities, and ultimately is a better use of financial resources. Another way that hospitals and healthcare systems are evolving is our role as anchor institutions. We're oftentimes among the largest employers in a community, and we are often economic engines. And that's particularly true in a smaller population area like Western Mass, where we are. We also can use our credibility and our voice to be advocates for policies and budgets that support public health and social determinants of health. And I'm going to talk about the community health needs assessment role in just a minute, and we can move on to the next slide. So I wanted to show an example of how I think of this in terms of this being a continuum of care. On the one hand, you have a focus on medical care for an individual that needs medical support, but we all live our lives in the context of our community, our family. It's not just about medical care, because ultimately, once the medical care is done, we're going right back into community. And so we need to think about policy and community level policy and other interventions. And so, if you think about just from the medical point of view, what good is a prescription for someone if they can't afford it? And what good is giving someone health education information if they can't read it? So thinking in terms of context and the whole community and the whole person, I think is critically important. You can please move on to the next slide. So health is a naturally occurring outcome of our daily choices and our behaviors. And those are all shaped by the opportunities that we either have or don't have in our families, our neighborhoods, our schools, our workplaces, and our broader community. And so collectively, those policy choices that we make just on a day-to-day, month-to-month, year-to-year basis do add up, and they are important because those environments are how we live our daily lives. And I'm not discounting the role of genetics and so forth. The personal characteristics that we all bring to health, of course, those are important too. But just want to acknowledge the importance of community and the context in which we live. The community health needs assessment we conduct every 3 years, and that provides an opportunity to us to connect with our community in a deeper way. So to understand what asthma rates might mean to a family, or what it means to a person if they can't find affordable housing or healthy, affordable food. Data is critical to that process, but ultimately the numbers only get you so far. You really have to get out and talk to people to understand in their day-to-day lives what those numbers actually represent to them. And then ultimately to solve problems requires those conversations and those partnerships between government, such as the Health Policy Commission, institutions such as hospitals, community agencies, such as the Collaborative for Educational Services, but probably most importantly, our people. And I think, do I have one more slide? Yeah, thanks. So that's why investments in projects like the Food Policy Council are so critically important. None of us alone can improve social determinants of health for everyone, but working together, we can learn, we can make progress, we can reach the outcomes that we hope to reach. And through projects like MassUp, we can create templates for change that other people in other communities on other projects can use and learn from. And so let me now yield to Kia Aoki to talk about her experiences as a resident helping to launch the Food Policy Council.
Hi, everyone. Thank you for coming today. So I'm going to start by talking about what it feels like to be us. So low-income people experiencing food insecurity are powerless to have any kind of input with the organizations and agencies that have decision-making power over the help that we receive. There is frustration, cynicism, and ultimately apathy within these populations because no one making those decisions have the same kind of lived experience and are creating policies driven by the fear that these people will be given too much or are using the system to get free stuff. The Hampshire County Food Policy Council is partly designed to give these people an opportunity to help restructure food systems that are keeping us from eating fresh and nutritionally adequate food to giving us access. Obviously, one's diet has a direct impact on the physical health and brain power. The Food Policy Council will provide mechanisms to help create policies to reverse harmful narratives and allow people to break down the barriers and suspicions that have governed their lives to having a voice in how they live. This work also has a tremendous impact on self-esteem and overall mental health because of the confidence and trust given to them to partner with the professionals to listen and help figure out ways to put these new policies in place. So often when the community has conversations internally, like between neighbor to neighbor, about these issues, spontaneous ideas pop up with wishing we knew how to make changes happen so children can go to school properly nourished and capable of learning at a high level, so our seniors can have a good quality of life through healthy eating. And for everyone else, the struggle to eat right can be a full-time job in some cases and will prevent otherwise smart and capable people from pursuing an opportunity for a better job or coming up with ways to implement ideas for an overall better life for themselves and their families. Constant struggle so often results in depression and other mental health challenges. There is no question that good physical and mental health are requirements for thriving, affluent, self-sustaining communities, and the Food Policy Council is partnering with us to make that a reality for everyone that have been traditionally left out of these conversations. The enthusiasm that we are generating is demonstrating that hope is beginning to develop, which is step one to finding the energy to grab an outreached hand and begin to climb out. Thanks.
I don't know if we talked about who it would come back to at the end, but thank you so much, Kia. And yeah, just wanted to leave on this slide. I think what Kia and Jeff have so aptly communicated is that we really need each other to do this work. None of us can do this work alone. These institutions can't do the work without the community, and the community can't do the work without us. And so bringing this Food Policy Council is just really a way to work together toward the outcomes that we all want to see.
And Caroline, if we have a few minutes for questions, we'd be happy to do that. And if not, we'd be happy to answer them offline.
Oh no, you don't get away that easily. We want to hear more about the success that you've had. So let me open the floor to questions from our commissioners. Chris.
Yeah, hello team. So I'm curious what businesses have become involved in the project, and the context for my question is that I know that I'm piqued. My curiosity is piqued by the slide that showed that 2/3 of the towns do not have a supermarket. My guess is those towns do have a store. It's probably a Dollar General or that small packed kind of store. I'm aware that Dollar General has begun an initiative to bring fresh fruits and vegetables into their inventories, and so I was wondering in particular whether those stores are involved, but generally what employers or what companies have gotten involved with you so far?
That's a great question. And I would say so far, we don't have a ton of engagement from businesses. We have one downtown Northampton restaurant that's been trying to get involved. We have some farmers who, have been involved in our conversations. And part of this work is that we actually have committees that have been coming together and meeting, around specific issues, and sort of alternative businesses like mobile market programs that have, already been in conversation that we're trying to bring under the umbrella of this work. I think you raise an awesome point, and it would be really interesting to think about, sort of the unusual suspects, who often are not coming to the table for food policy councils or groups like this, and thinking about how to recruit them, particularly in the hill towns, in that region of the county. You're right, there's a lot of businesses that are really sort of oriented toward their communities. And of course, the challenge with business owners is always just time. And, running a business takes up a lot of folks' time. So there's lots of ways that folks can get involved and get engaged in the conversation without necessarily, being a decision maker in the Food Policy Council. And I think we're all really interested in exploring, how to open up these conversations and bring in as many partners as possible.
And Caitlin, just to add just a little bit on that, in terms of Dollar General specifically, we really don't have that store in our area too much. There are some Dollar Generals in Hampden County, which is to our south, and one in South Hadley, which is in Hampshire County, but close to Hampden County. We've been doing food systems work for a long time. MassUp is not our first food-related initiative. And there have been some other projects over the years where convenience stores have gotten involved, particularly ones that are locally owned and operated by people who live here and have families here. The chains, not necessarily so much. So I think it's a great question, and it is possible to engage folks. Particularly on that map, you might have noticed an area in the upper left corner that was very, very red. That area is known as the Hill Towns. It's very rural, and there have been some efforts to engage businesses in that area that have been experiments, and at times have shown promise and have at times have not worked quite as well. But again, as I said earlier, I think this is very much an experimental project, and who knows where it will lead. But thanks, thanks for asking that question. I think it's an important one.
Thank you. Other questions from the commissioners?
Barbara, if I could.
Yes, please, Marty.
First, let me commend everybody. This is great work. The foundation that I'm involved with is trying to get a food policy council established, so I know how hard this work is. I also want to compliment Cooley Dickinson because I think it's the approach to understanding not only the importance of this work for patient care, but also the leadership that a hospital can bring to looking at the social determinants of health. And clearly the governance model that's being presented here is different in that it is shared decision-making, which, I think for lots of folks takes some getting used to, but it seems to be working. And so I commend you for that. And I'm curious, in the work that we've been doing locally to try to get a food policy council established, we've run into some resistance from, interestingly enough, emergency food providers, meal programs, pantries, distribution sites. I'm just wondering if you've sort of encountered similar resistance or sort of where the resistance has been to the efforts that you're promoting.
I can take that, and happy to let Jeff or Kia add anything. But I would not say that we've really experienced significant resistance from emergency food providers. A couple of the really a few of the initiatives that were funded by our grants from our discretionary budget or mini grants for emergency food providers. That's a nice way to bring those folks into this work and really sort of encourage them to, think about how they might connect their work to sort of broader efforts going on in the county. I'm so tempted, Martin, to turn your question back around on you and just learn a little bit more about that resistance and where that's coming from, but maybe that's a whole other conversation. And I would say, I wouldn't say that we have faced a lot of organized resistance that feels insurmountable in any way. If anything, it's maybe just folks kind of wondering, what is this? And, why is it important? And why should I get involved? And, sort of just needing to learn a little bit more and understand a little bit better before, they decide how they might like to be involved. But it's a great question.
I don't have more to add, but I do want to invite Kia to take herself off mute and talk just a little bit about the national project through Johns Hopkins that you're representing us to.
Yeah, so this is actually interesting. Somehow I wound up getting invited to participate in a project that Johns Hopkins is doing. It's called a community practice, and it's gathering food policy councils from all over the country. So there are 50 of us that are representing food policy councils from every state. And myself and Talia Segovia from Collaborative for Educational Services is my partner in this. And we meet once or twice a month, depending if there's an extra thing happening. And we get together to share ideas, to help each other establish food policy councils, or teach each other how to get community members involved. And it's where what they plan on doing is they want to build a network of food policy councils and put all of us like under some kind of an umbrella. We just had a meeting last week about federal policies around these issues. So I think that we're heading towards the direction of having like a national food policy council advocacy group coming up. So it's pretty cool what's happening. But I've also noticed that there are different levels of food policy councils like throughout the country. So there are some food policy councils, most of them surprisingly are on the East Coast, that are well established and are doing well and are able to get the work done and have ways to have access to community members, which is a big question that I get all the time. Like, how do you get people to participate in these types of things? And the bottom line is you have to compensate them for their time. I mean, they have to recognize that what they can contribute, and their value needs to be recognized. So that's, and that opportunity came directly from Caitlin introduced me to these people. So I thank you for that, Caitlin. And it's just been really awesome just having like all these different projects I'm involved in. And I also wanted to say, in answer to Martin's question, is that I really feel like the emergency food systems organizations like in Hampshire County have been really open about partnering with us and are really interested in having a circle on the Food Policy Council, for example. And I think all of these things are happening simultaneously, which is really cool. So I think we're going to be really successful moving forward. I'm very excited about this work. I am so excited. And, I'm just like a normal person living in low income housing, and then I have all this opportunity coming up, to see real change for, people in my community. And, there's hope springing up. It's like, oh my God, somebody's listening. If you feel like somebody really cares about what's happening to your life, it provokes this motivation, like your self-motivation comes alive. Like there's stuff I can do, that people care about what I think. This is really important, and I think that's part of the mental health part of what's happening here also. So yeah, thanks.
Kia, you were just so wonderfully articulate and your enthusiasm just shines through. Thank you so much for sharing that. That's wonderful. Other questions? Because I have a couple, if I may. Two things, and Kia, one of the questions is going to be to you, but I'm going to ask that second. What, if any, activities are you doing or are you thinking about doing that is along the lines of community gardens or ways in which people can be involved in seasonal food harvesting? And do you have any plans along those lines? What are your thoughts?
Kia, I'd love to have you chime in there, and then I can fill in after the fact.
Okay, so in 2019, Caitlin and some of her partners came to Hampshire Heights and asked us if we wanted to have a community garden built. And it was being funded by, I think, the United Way. Colleen Dickinson was involved. And there was a bunch of residents, and we were like, yeah, that would be great. And so they came and they built the garden, and we started gardening. And the first year was really successful. It was wonderful. And we harvested. We had a cooking club that we used all the stuff that we grew, and then we shared recipes and hung out, and it turned into this Friday night potluck. And then COVID happened. Yeah. So that was so 2020 kind of just disappeared, for everybody. But in 2021, we got the gardens back up and running. And this year we have the garden connected with a playground that is recently under construction in Hampshire Heights. So, we're hoping to have, kids be able to run in and out of the garden and pick strawberries and learn about how to grow food, things like this. So, it's an ongoing project, but it's definitely one of our favorites.
Yeah, what you just said absolutely anchors my own experience and my own understanding that food can become the center of community. And community is not only about eating it, but I think most especially and most energetically about the growing and preparing of it. What people learn, how people partner, how people collaborate is all represented in a community garden. So it sounds as though you've hit it off perfectly. And I really encourage you, as quickly as you can get back to the community component of the garden would be wonderful. Congratulations. My second question, Kia, is to you. And as an active community participant in the program, could you, if you can, identify one or two aspects of what this program did that was completely engaging for you and for the other community participants? What did they do absolutely right?
They gave us the power and equal power to make decisions about what happens and how it happens. I mean, that was huge, because, so many times when you're dealing with agencies and, people that want to help you, but they don't really know you. So the help is kind of weird or suspicious, it comes under this cloud of suspicion because people generally think low-income people are just lazy or whatever the narrative is out there. And so this gave us an opportunity to undo that, and to say, hey, we're people, we have brains. A lot of us are here because of like some unfortunate circumstances, or, there's a whole plethora of reasons why people live in low-income housing, and this gave us an opportunity to educate other people and other people in that have positions and fancy degrees, what it's actually like to be us. And I think this has been really empowering, especially for me and a couple of my neighbors. It's been very empowering. And, there's this, again, it's this self-motivating factor. If somebody's paying attention to what we think, we are so much more motivated to be involved and to help and to offer our time. And, like we're all volunteers, so I don't know, they're doing something right. I think they're paying attention, and they invited us in, and they created all of us together created all this wonderful thing that's happening, so I am so happy that that this is actually a thing. It's just been great.
I'd like to add something, and as everybody can see, working with Kia, it is infectious, and it's wonderful, your energy. To put a little bit of research to the conversation, though, there's been long-running research out of Chicago led by Robert Sampson from Harvard on community efficacy, and it shows that when people in communities come together to identify the issues they want to work on and the solutions they want, the change sticks around a long time, and health is a naturally occurring outcome of that. It's really not appropriate for an outsider, me, for example, or any of us, to come in and dictate change to people. It's really that partnership that Kia referenced is where I think the magic lies. How do we do that together? To use, in this case, the hospital's voice, maybe a little bit of our money here and there, to support the community, and for the community to feel empowered to really take control over the decisions that are getting made.
Jeff, I think I'm particularly thrilled with this because in my early days, I was a VISTA volunteer in Greenfield in Franklin County, right up the road. And I know the area pretty well. Don Berwick, who is a commissioner with us, has said for years and years and years, nothing about us without us. And he was talking about patients. In this instance, we're talking about the community that you're trying to serve. Nothing about us without us. It's a very basic concept, but so many people, especially people in professional roles, don't take that step, don't respect that step, and don't respect the input of the people they're trying to serve. You won't get good outcomes if those folks aren't there, and it's their lived experience that you pay attention to, and their lived needs that you pay attention to. So, I could listen to you all day, and maybe at some point might want to. So I might hit the road and come out and see you at some point. I don't know if there are. Well, I know my way there. I know how to get there. Yes, exactly, Kia. And so I just want to encourage you to keep doing it, what you're doing. We're thrilled that our seed money has helped you along this path, and we look forward to seeing the outcomes going forward. We hope you sustain this. We hope you flourish with it, and we hope you grow it. And unless there are any other questions, I just want to thank you ever so much for joining us today and for sharing not only with us, but the viewers who are watching now or who can see this on YouTube. But by the way, you can see yourself on YouTube too if you wanted to check yourselves out, but you did really, really well. So if there are no other questions, I want to thank you very, very much. Invite you to continue to hang in if you'd like to, but we have some other really important work that we need to do, and unfortunately there's never enough time to get through it all. So again, thank you very much, and Caroline, you make sure that they come back and see us. Okay,
I will. Thank you.
Thank you, everybody.
Thanks so much for your time. Have a good day.
Oh, you're very welcome. Take care. Okay, we need to now move on to another very important part of the work that we've been doing, and that's our Quality Measure Alignment Task Force. And Kelly, I'm going to immediately reach out to you.
Thank you so much. I feel like I have the unenviable task of going second here. But as you know, one important tool we have for raising the bar on healthcare quality in the Commonwealth is the Quality Alignment Task Force. force. Representing the HBC in this cross-agency effort is HICD Associate Director, Vivian Jaime, who's here to introduce some important new work from the task force and follow up on a presentation that she made last spring. So Vivian, why don't you take it from here?
Sure. Thank you, Kelly, and good morning, commissioners. Today, we're excited to release our 21st DataPoints issue, highlighting the work of the Quality Measure Alignment Task Force and findings on payer adherence to the Massachusetts Aligned Measure Set. As a reminder, Massachusetts has been engaged in a voluntary process of aligning quality measures with the goals of reducing administrative burden on providers and payers and focusing quality improvement efforts on high priority areas. This process began in 2017 when EOHHS convened the Quality Measure Alignment Task Force to make recommendations on an aligned measure set for voluntary adoption by Massachusetts payers and providers in their global budget-based risk contracts. In order to track adoption of the measure set on behalf of the task force, CHIA and the HBC issue the Quality Measure Catalog Survey on an annual basis, by which payers report the measures included in the risk contracts for the subsequent year. I presented some of this data at the June CDT meeting, as Kelly mentioned. And as you may recall, it was actually your idea to develop a DataPoints issue on this topic to bring more transparency and accountability to this effort. In the next couple of slides, I'll share some of the findings included in the DataPoints, which we prepared in collaboration with our colleagues at CHIA. Next slide, please. So the first thing I'll note is that the task force has agreed on a number of different measure categories, which you can learn more about when you visit the DataPoints on our website by hovering over each slice of the pie. Of note, core measures are meant to be adopted by all payers and providers in their risk contracts, whereas menu measures, as the name suggests, include additional options that payers and providers may consider for inclusion. Developmental, innovation, and on-deck measures all represent areas of innovation, measure development, and gap filling. And finally, monitoring measures are ones with limited opportunity for improvement, but which the task force tracks in case performance slips, in which case the measures may be reconsidered for inclusion in the core and menu sets. I'll note, as you'll find in the table at the bottom of this slide, that at present, core measures, which indicate high priority areas and include meaningful measures of health and behavioral health care outcomes, such as diabetes control, blood pressure control, and depression screening and follow-up, have not been universally adopted across risk contracts. In some instances, payers have not included these measures in a single global budget-based risk contract, as the table reflects. The next slide, if we can turn there, highlights the overall trend in adherence to the aligned measure set. Adherence is calculated by taking the sum of instances endorsed measures were used in risk contracts over the sum of instances any measures, including endorsed or non-endorsed, were used in risk contracts for a given payer. As you can see, overall adherence to the Massachusetts aligned measure set has improved in the last few years from 61% to 83%, but payer adherence is variable. Next slide, please. While voluntary payer commitments to alignment show some promise, absent a legislative mandate, it is unlikely that full alignment will be achieved. We thought it might be helpful to provide some national context on how other states have approached their quality measure alignment efforts. Quality measure alignment in the broadest sense involves multi-payer adoption of a common measure set for the purposes of transparency, provider tiering and product design, and/or contractual accountability. I'll share some examples of what other states are doing, with the caveat that this is our understanding based on publicly available information, and that this may not be a comprehensive picture of all quality measure alignment efforts in other states. Based on our findings, in at least 7 states, quality measure alignment efforts have been initiated or accelerated through statute or executive orders. A few states began their efforts with state innovation model funding or voluntary mechanisms, such as private coalitions. Only 2 states that we know of mandate adoption of a common measure set for some or all risk contracts, including Rhode Island and Oregon. In Rhode Island, measures are established through commercial insurance regulation, and Medicaid voluntarily aligns. In Oregon, legislation mandates adoption by Medicaid, the state employee and school employee purchasing programs, as well as plans sold through the state's health insurance exchange. Other states take different approaches to promote adherence. For example, in Minnesota, legislation does not mandate adoption of the common measure set, but it prohibits payer use of measures not included in the common measure set. In Massachusetts, there may be an opportunity in this legislative cycle to codify the work of the task force and accelerate adoption of the Massachusetts aligned measure set. Next slide, please. I'll now switch gears and provide an update on the health equity efforts that the task force has undertaken. First, when the state reopened the procurement for task force members this last summer, EOHHS added a goal specifically tied to advancing health equity. The charge of the task force is to advise EOHHS on the measurement and reporting of health and healthcare inequities and accountability for reducing such inequities. Next slide, please. To support this goal, EOHHS convened a health equity technical advisory group, which consists of 3 subgroups. The first group, the data standards group, will recommend a standard for the capture of social risk factor data, including race, ethnicity, language, disability, sexual orientation, and gender identity, as well as an approach for promoting and assurance completeness and integrity of this data. Another subgroup will advise on approaches to measuring and reporting on health and healthcare inequities, and this role will be filled by the existing task force. A third group, the Health Equity Accountability Group, will recommend approaches to introducing accountability for reducing inequities and ensure providers serving population with disproportionate social risk, as well as the healthcare consumers attributed to them, are not unfairly disadvantaged by the introduction of accountability for reducing inequities. CHIA, Mass Health, and the HBC are jointly funding the facilitation of the 2 new health equity technical advisory groups, which kicked off their work last week and will be meeting monthly or more frequently through the spring and possibly summer. I look forward to providing an update on this work at a future CDT meeting once these groups have made their recommendations. And with that, I'll conclude this presentation, and I'm happy to answer any questions or open it up for comments.
Thank you so much, Vivian. Are there questions?
I didn't see always listed as a payer, and I wonder whether you're working to get them involved as well.
Thank you. Yes, we have reached out to them. They have not submitted data as part of the quality measure catalog in past years.
Huh. Are they not interested, or they just, have you talked to them, or? Because they're a payer, but they're also a provider. They're very linked in with the provider, obviously Mass General, Brigham. And so I would think that over time they could become important.
Yeah, that's great feedback. We can definitely think about how to engage with them.
I think part of the question, though, is are they resistant, or I mean, what's the status of their not participating? I think is the question.
Yeah, that's a good question. I'm not sure I can comment on that at this point, since we haven't met with them specifically. I know we have issued the survey, for them to let us know what measures they're using in their risk contracts, and I'm happy to follow up with our colleagues at CHIA to see if they might have more information on why they haven't responded to that survey request.
Okay, Stuart, is that helpful?
Yes. Yeah. No, I just they're new. And they're trying to get their legs under themselves. So I can see why this might be, something they haven't focused on. But over time, I think their plan is here to stay. So we might as well get them involved. They're important.
Absolutely.
Great. Thank you, Stuart. Other questions or comments?
Barbara, just following up on Stuart's comment. First of all, I want to commend Undersecretary Peters for her work. I know she's led this task force, and it's come a long way. So thank you, Lauren. But I noticed sort of Health New England is the laggard in the terms of the percentage. Is anyone working with them to try to see what the issue is with their acceptance of the measures?
We did follow up with them after last year's survey, and we just actually issued the quality measure catalog and are in the process of analyzing the latest data. So I can follow up with you once we've taken a look at that. I know for a number of payers, part of the reason for not adopting the aligned measure set were legacy contracts, which made it, I think for health, I think in this case in particular, several of their contracts were wrapping up this year. So we might see an uptick in their adherence in the coming year. But I know that was certainly a reason that was noted for many payers for not being in adherence with the aligned measure set.
Okay, any other thoughts or comments? Lauren, thank you so much. I know you just said that you had to drop. Okay, then hearing none else, Vivian, thank you so much for the report. We look forward to hearing more as time goes on. And we are now ready to look at the cost-effective coordinated care for caregivers and substance-exposed newborns. So Kelly, back to you.
Thank you so much. And thank you for saying that long name so that I don't have to. So about a year ago, the board approved awards for C4SEN, which is how we make that name roll off the tongue a little bit more easily. The C4SEN investment program, which is our most recent effort to address the impact of substance use disorders on infants and families. I think that as Caitlin remarked, COVID time is weird. It's hard to believe it's been a full year, but I will say that this past year has brought quite a bit of activity among those awardees, and certainly a lot of learning about program implementation in these, shall I say, euphemistically unique times. To share a status update is Molly Sass, the C4SEN program manager. Take it away, Molly.
Great. Thanks so much. Good afternoon, commissioners. As Kelly said, I'm here to present an update on where we are with the program, a brief overview of our awardees and where they are, and then some of our next steps. So just a reminder that the HPC was charged with developing and administering an investment opportunity to support a model of care that includes both medical and traditionally non-reimbursed services. Continuing our work, as Kelly said, in this work stream where we've supported neonatal abstinence syndrome programs and supported the adoption of the Moms Do Care program. C4SEN program is specifically focused on supporting and engaging birthing people and their infants through 12 months postpartum. Additional program components include ensuring coordination with medical and behavioral health care, especially supporting access to medication for opioid use disorder. We're looking to make sure that these awardees are providing care that is free from stigma and bias and ensuring staff are providing culturally competent care. Awardees also need to provide linkages with social services to support caregivers and their infants with health-related social needs and connection to early intervention. Next slide, please. The C4SEN program remains relevant and provides essential care in the midst of the continuing opioid crisis. I think we've seen these numbers before, but just pointing out that the rate of overdose deaths has remained high. And we've seen that in the first 3 months of 2021, that they have remained consistently high as well. Next slide, please. While current data on substance use during the COVID-19 pandemic is still rolling in, a January 2022 preliminary analysis of DPH's COVID-19 Community Impact Survey suggests that substance use among Massachusetts residents has largely stayed the same or increased since the start of the pandemic. And just noting that respondents who reported having an increased substance use compared to before the start of the pandemic were more likely to identify as trans, non-binary, or cis female, multiracial, Hispanic, Latinx, Black, non-Hispanic, non-Latinx, and Asian, non-Hispanic, non-Latinx, and have an identified language, a primary language other than English. Next slide, please. So this leads us to an important point, that the consequences of the opioid crisis do not affect Massachusetts residents evenly. Indeed, the crisis yields differential impacts across individuals of different races, ethnicities, and genders. As you can see from the graph at left, in the first 3 quarters of 2021, Hispanic and Black non-Hispanic Massachusetts residents suffered from opioid-related overdose deaths at disproportionately higher rates than their white non-Hispanic and Asian non-Hispanic peers. In addition, compared to 2019 data, the opioid-related overdose death rate among women increased by 15% in 2020, noting that the rate among Black non-Hispanic women increased by 32%, and for Hispanic women increased by 68%. Notably, survey respondents, especially those using cocaine, heroin, or other opioids, reported interest in services related to counseling, tobacco cessation, peer and recovery support, suggesting that there is an ongoing unmet need for support and treatment services. Next slide, please. In the context of the intersection of the COVID pandemic, opioid epidemic, and structural inequalities, our 5 C4CEN awardees are working to support birth parents and their infants. These programs focus on birth parents. We use the term caregivers, and while this often includes mothers, we do want to be inclusive of non-female identifying birth parents. The 5 awardees are serving geographic spread across the Commonwealth, serving some rural and urban communities. Some are building new programs and some are expanding existing services. While each hospital has taken a slightly different approach to addressing the core program components, all awardees are engaging pregnant and parenting caregivers with infants under 1 year of age and ensuring active support throughout their engagement with the program. So I'm just going to take a few minutes to kind of run through the 5 awardees that we have. Next slide. Bay State Franklin is building on their Moms Do Care program by creating a multidisciplinary family clinic where caregivers and infants can be seen in joint appointments with both primary care and behavioral health providers. Next slide. Berkshire is creating a net new program intended to streamline the referral and coordination with local obstetric and pediatric offices and treatment providers. Next. Mercy Medical is piloting a new technology platform to streamline existing services and improve interdepartmental communication. South Shore is building on existing services within their perinatal behavioral health program, including introducing new supportive staff roles and patient assistance funds. And lastly, the team at South Coast is expanding their existing services to meet the growing waitlist and facilitate communication among community providers. As the C4CEN awardees transitioned out of the planning period and into implementation that happened in October of 2021, all placed a strong focus on establishing new and strengthening existing working relationships with community-based providers and services to bolster referrals and ensure a continuity of care for caregivers and their infants. The feedback from these partners provided was promising. They were pleased that awardees were standing up and building out these programs and making concerted efforts to promote cooperation, lay the groundwork for reciprocal referrals, and break down silos in the provision of care. Implementation has not been without its speed bumps, however. The COVID-19 has in turn caused slowdowns and inspired changes in practice. Nearly all our awardees have encountered challenges tied to staffing. Shortages leading to reduced bandwidth and difficulty hiring new personnel have made for slower ramp up than some awardees anticipated. At the same time, awardees are increasingly relying on creative ways to engage participants and meet their needs. Some initiatives have begun communicating with caregivers via text and phone, meeting participants where they are and when they are available. One awardee has begun organizing toy and clothing drives to provide caregivers the goods they need for themselves and their families during later times. Next slide, please. So while the awardees continue their work on serving caregivers and infants, our team internally is focusing on our evaluation plan, a mixed methods approach, including quantitative and qualitative deliverables from awardees, as well as a patient experience portion, which will be conducted by our contractor, JSI. Much of the final program evaluation report will draw from this quantitative and qualitative data that our evaluation team will collect periodically from awardees over the course of the program. These quantitative measures tie directly to the program's core components and will provide an opportunity to review data broken down by race and ethnicity. One core program component not fully captured in the quantitative data is that around caregivers' experience of stigma and bias, especially because of caregivers' intersectional identities, including their race, ethnicity, and opioid use or OUD diagnosis. We think this component is best assessed through surveys and interviews of caregivers, which JSI will conduct in close collaboration with the HPC. We believe that these methods will capture the breadth and depth of the caregiver experience and their interactions with all parts of the C4CEN programs, including medical and behavioral health care, social service agencies, and interactions with other individuals. Next slide, please. So as we wind down our update on the C4CEN program, I do want to share a patient story from one of the program awardees, South Coast Health. This patient's experience underscores the life-changing impact of the meaningful work done each and every day by the C4CEN awardees, made possible through this important grant funding. So this caregiver was living in a residential rehabilitation facility and relapsed midway through her pregnancy. She was referred to the New Beginnings Initiative at South Coast Health by her mental health provider. From the outset, she was eager to engage with and actively participate in the program, requesting more frequent virtual meetings than the program's original schedule. As she worked with the New Beginnings team, the caregiver was able to open up and share her concerns around DCF's involvement following delivery. While she was eager to actively participate in treatment, she knew that doing so would trigger an investigation by DCF after birth, which could result in the loss of custody of her infant. Having heard about other parents' experiences, one of her priorities in participating in New Beginnings was to make sure she was fully prepared for the DCF process. The team worked closely with DCF and this patient, and the caregiver was able to ensure that she got the answers to her questions and was really set up for success. Thanks to the caregiver and the New Beginnings team's hard work, she was able to bring her baby home from the hospital. Today, she lives in an apartment on her own in a step-down placement and continues to engage regularly with the New Beginnings initiative, proactively contacting the team between regularly scheduled appointments with questions and updates. New Beginnings provided the caregiver a productive and safe outlet to air her concerns, not just to vent, but to actually get the help and support that she needed to make sure that she achieved her goal of taking her baby home. Reflecting on the initiative in her own words, she shared, "I can't stress enough the support I felt with New Beginnings when my son was born and DCF got involved. It was truly a blessing to my family to have these ladies advocating for me and being there for me whenever I needed them to be." This is just one story and of one caregiver and one awardee. But we're looking forward to gathering more of these and really being able to acknowledge the caregiver experience with more stories to come. Happy to pause and answer any questions.
Thank you, Molly. Another great emerging outcomes. Questions for Molly? I guess not, Molly. Thank you so much for overseeing this program, and I know we'll continue to hear back from you. Sounds like we've got very good outcomes here and looking forward to even more. So thank you. We need to go back to the minutes before Colleen sends me another message to tell me to remember to do that. And Colleen, I don't know if we have a quorum to do that again.
We
Did
do.
we lose it? Oh, we do. Okay.
Just by the skin of our teeth. So we'll just
Okay.
quickly, if I could get a motion on the minutes
So moved.
and a
Thank you,
second.
Marty.
Is there a second? Thank
Second.
you, Barbara.
Yeah.
Great. And we'll start with you, Madam Chair.
Aye.
Commissioner Cohen
Aye.
and Commissioner Kreider.
Can you hear me? Aye.
I can hear you. Yes. Thank you. Thank you so much.
Phew. Sorry about that, Colleen. Okay, let's just make sure we have our schedule of upcoming meetings clear and understood. Colleen, do I go back to you for that?
Absolutely. So the next meeting of the board actually is going to be our benchmark hearing, which Executive Director Seltz talked about at the last meeting. So this is a meeting co-hosted with the Joint Committee of Healthcare Financing from the state legislature. It's where we solicit testimony from market participants as to where to set the benchmark for the upcoming year. And this year will be the first where the board can actually set the benchmark at any range, which would then trigger a legislative process. So it's a very exciting year. So folks, please sign up, please register for that. And that'll be the next meeting of the board. And then our next committee meeting is actually going to be May 11th for you, Chair Blakeney.
All right. May 11th is a very good day.
Great.
Okay, any other questions or comments before we conclude? I think we have finished our plan for business. Any other thoughts or comments? Okay, then hearing none, thank you all for participating, and